Whenever you want, I can start.
Okay. Good evening, everyone. You are most welcome in our third webinar for this year. Hope everybody is staying at home, staying safe all over the world. Welcome of our colleagues and participants from outside Palestine. I think we have at least 15 persons from outside Palestine. So welcome. And in new names, I welcome Nasib Balut, Professor Balut, our friend and a friend of our Palestinian people, Mexico, from Beirut, from Lebanon. He's going to speak about surgery first options and orthodontics. So you are most welcome, Dr. Nasib, and thank you very much for joining us for this lecture. Thank you much. The stage is yours.
Okay, thank you very much. This is a great pleasure being with you, with all my Palestine friends. And also I welcome all the people which is not from Palestine that is connected to this webinar. So as Ahmed says, I hope everybody is safe. In Mexico, we are just starting, that the curve is starting going up. So let's see how it's gonna end up in Mexico City because of the population. But inshallah, everything stays like every place. The less amount we wish, the less amount people get sick. So let's start. Today I wanted to speak about surgery first approach. Thank you for the invitation to my very good friend, Dr. Saad, and all my friends from the Palestinian Orthodontic Society. So when we wanted to treat a surgical case, now we have like 3 options to do this combined treatment, ortho and surgery. We can do it the conventional orthodontic surgery. We can do the early surgery, and then the surgery first approach. Let's talk very little about the conventional orthodontic surgery. I think everybody was taught to treat these cases like this, that we have to do a pre-surgical dental alignment, then to do a decompensation of the anterior teeth, have a very good arch coordination, then do the orthodontic surgery. And after that, finishing with the orthodontic treatment. So with this, it should to have a considerable increase in treatment times. I'm going to show you a case. This case was treated by me when he had about 9 years old. Her mother had an orthodontic treatment. She had a mandibular setback, and her mother was concerned about his boy. She didn't want him to pass through the surgery. But the patients had very bad cooperation. I remember that we placed him on a face mask. He has that tendency of growth. So he almost spent, here is him at about 19 years of age, when we were planning him to have the surgery. So it took us a long time. He never used the face mask. We prepared him for the decompensation, and it was a really long ortho surgery combined treatment. There are some cases that we don't feel that confident in order to do the surgery first approach. So we can do the early surgery. I'm gonna show you one case, probably one of my worst class 3 cases that I ever had. She came to my office recommended by the surgeon because she heard something about the surgery first, and she didn't want to spend that long with braces. She never had an ortho treatment in the past. She had a very severe class 3 with an open bite. It was almost like a reverse curve on the lower arch. So when I was planning the case with the surgeon, at that time I was not feeling that confident to proceed with this case and go for a surgery first approach. So we decide to level and align mainly the lower arch and then do the surgery. That's why we call it early surgery. So that's what we did. I'm gonna go back a little. Now, if I have this case now, for sure, I will start it with the surgery first approach right away. At that time, I was in my learning curve. So that's why I was not feeling that confident to treat this type of a case. So we can see the class 3 relation that the patient had, a severe class 3. So we did the predictions, and we were planning to do a mandibular setback and maxillary advancement, and also a genioplasty. That at the end, the patient didn't want the genioplasty. I will show you the case. So this is the amount of negative overjet that the patient had. As I said at the beginning, she never had an ortho treatment in the past. And after probably between 6-7 months of preparing her with brackets, our main objective was to level and align the lower arch, upper and lower arch, mainly the reverse curve that she had in the lower arch. So this is her, more or less 6-7 months when we were ready for the surgery. As long as we have a better occlusal plane, then we felt more comfortable to do the procedure. So we placed the surgical wires and we were ready to do the surgery. As you can see, it took about 6 months to level mainly the lower arch to prepare her for the surgery. This is her left side. We then did the surgery models to find out the amount of the maxillary and the advance of the maxilla and the mandibular setback. This is her after the two-jaw surgery. As you can see now with the fixed, rigid fixation, upper and lower arches. And this is her at the 9 months of treatment, where we were almost getting ready to finish her. She, on the predictions, she didn't want to have the genioplasty, but I think she will be looking better if we move a little back that chin. Anyhow, this is the way we treated her with the early surgery. As you can see, the initials right before the surgery with the surgical wires, and this is after the surgery. This is when we deboned her. It took us about 11 months, I'm sorry, to finish her up. So as I said, we didn't want to do the surgery first approach in this case because we didn't feel that comfortable with this type of bite that she had it. And I was in my learning curve. This is her before and after. So anytime I feel that I don't feel that comfortable, or the surgeon doesn't feel that comfortable in doing the surgery first approach, now we do early surgery. It's very rare that we do the ortho surgery, the orthodontic surgery, the conventional treatment anymore. So let's go to the topic. The surgery first concept was developed mainly to reduce treatment time. Plus, we have the advantage of the RAP, which is known since Cole published the interdental corticotomy in the crowded lower front to accelerate orthodontic alignment in the 50s. So, as I said, one of the main objectives of the surgery first approach is just treatment time. And I think it's ideal for class 3 cases. In a class 2 with a mandibular retrusion, in a very short mandible, that's the only case that I will wait and don't do surgery first on those cases, because right after the surgery, we have to leave them in a anterior crossbite. And a lot of these cases, they have a severe curve of speed. And on the back, we won't have any occlusal contacts right after the surgery. So me and the surgeons, we don't feel that comfortable in doing this type of approach, just in those cases. But I will say that in my practice, probably of my surgical cases, more than 80% of them, we do it with the surgery first approach. So now we have a lot of literature that they talk about this procedure. And probably one of the main doctor that has been talking about this is Dr. Sugawara. And he has a different approach to decompensate the patients. I'm gonna talk later on. So at the end, I will leave you my email. So anyone that is interested in the literature, I can send you some, and I will be more than happy. So this is the Sugawara protocol for surgery first. In a class 3 patients, he makes the patient a severe class 2, and that's why he develops his plates to use some intermaxillary elastics and then finish the case. Our approach that our protocol that I will show you later is we don't want to decompensate as much the patients. I don't think we need to decompensate that much our surgical patients. We don't find the reasons why we have to do that big decompensation. So again, one of the main objectives of the surgery first approach is to reduce treatment time. There are some advantages for the surgery first approach that we will have immediate results. We will have the change in the facial appearance, the self-esteem and psychological environment of the patient will change right away. We will need the pre-surgical orthodontic phase. And I think this is very important, that we will have a new functional, dynamic, and balancing soft tissue right after the surgery. Plus that we reduce the treatment time, and also we have the wrap. Of course, we will have some disadvantage too, and we have to consider them. The orthodontist and the surgeon must be experienced and needs to plan very good treatment in advance. So that it will be more close cooperation between the surgeon and the orthodontist. It seems like all surgeons, every time when I start doing this type of approach, the surgery first approach, and talk with some old surgeons to start doing it, they didn't want to, they didn't feel comfortable about this procedure, because all of them are thinking more in the Sujawara protocol, and they think that if you don't have that tripodism right after the surgery, it will be difficult for stability on the cases. The orthodontic treatment will start as an average 2-3 weeks after the surgery, and we have to see our patients. The appointment intervals will be every 2 weeks, taking advantage of the wrap. And we know that the wrap effect, it takes 3 to 4 months. So that's why we want to see the patient, the intervals every 2 weeks. As you can see in this patient, that she has a mandibular advancement on a surgery first case, that we will see the change immediately. So the patient, we place the brackets 1 or 2 days before surgery, and when they come out of the surgery, they will see the changes right away. So the cooperation and the motivation of our patient and their self-esteem improves a lot. Let's see. This is the case that we just saw. This is her just 8 days after the surgery. Of course, we will see all the swallow, but the changes on her face and the motivation that the patient will have will be much better. In the opposite side, in the conventional orthodontic surgical cases, like in a class 3, sometimes it takes 1 or 2 years to decompensate the patients. And during the ortho treatment, the pre-surgical ortho treatment, we will make the patient to see worse. And this, for their self-esteem, is not good. So now with the surgery first approach, it changed. So the motivation and the acceptance for the procedure is much more easier. Again, I show the case I showed you at the beginning. On those class 3 cases, we have in a conventional surgical orthodontic case, we have to decompensate, and it takes a long time before the surgery takes place. So one of the main advantage of the surgery first approach is reducing treatment time. Most of my cases that I've been doing with surgery first in the last 4 or 5 years, the treatment time average, in all of the cases, is about 11 to 12 months. So I think this is a great advantage. Plus that we have the wrap. it has been shown in the literature that just with the cuts of the surgery, we will have the wrap. So the teeth will move faster. So we have to take into consideration some factors for this approach. We really know the know-how in the surgery first. The surgeon and the orthodontist. We have to work out with an open mind surgeon and good attitude. As I said before, it should be a very close communication between the orthodontist and the surgeon. Actually, we have to do two predictions. The first prediction is the way we want to see the patient right after the surgery. For example, in a class 3 case, I will need to see a light class 2 right after the surgery. What will be the amount of overjet that we will need to see? It will depend on the amount of torque that we want to do on the lower anteriors. But we will talk later about this. And also to do the prediction, how it's gonna look at the end of the treatment. We have to be aware of the occlusion right after the surgery. And probably this is one of the main concerns of a lot of orthodontists when they do this type of approaches. So, as I said, the surgeon and orthodontist must know what to do in the surgery first, and needs to plan the orthodontic treatment according to the decompensation that we will need it. So we have to be, with the communication, we have to be very accurate in the way we want to see the patient right after the surgery and the occlusion that it will be expected that right after the surgery. Some cases, and that's why I don't want to do surgery first in class 2 with the short mandible with a deep curve SP, is because right after the surgery, we won't have any type of occlusion on the back. And this will be very difficult to handle. And probably we will compromise the stability on those cases. As I said, we have to work with an open mind surgeon that will accept what are our objectives. This is one of the surgeons I work with in Mexico City, Dr. Juan Jose Trujillo. He's a very conservative surgeon. I know him since a long time, and the first time I talked to him that I wanted to do this type of approaches, the surgery first approach, and because he's working in a government hospital and they see a lot of patients, so I told him, I won't charge the patients, the ortho treatment. I want to document and let's do a good number of cases. So when I asked him, he looked at me and he almost take me the temperature and he told me, are you crazy? You want me to do surgery first with you? He was just aware of the protocols of Sujawara, and he didn't like them at all. Again, when I talk with Larry Wolford about this, he's completely against this type of procedures. And that's why I said that we have to be working with some open-mind doctors, that they are open to learn and to see the cases. So when I show Dr. Trujillo our protocol, and because we are very good friends, he started doing it. And now he's even sending me and recommend me patients to start this type of procedures. And as I said before about the self-esteem of the patient, I will recommend you to read this article about Surgery First that talks about the level of satisfaction and the quality of life comparing with the conventional orthodontic patients. So always in a surgical case, we need a lot of communication between the orthodontist and the surgeon. But here, the communication has to be much more close. The surgeon and the orthodontist, they really must know what do they have to do on the treatment. This is the other surgeon I'm working with, Dr. Calleja. I know him since high school. We are very close friends. So that was very easy to convince him to start doing the surgery first approaches. He works in a private hospital, and it was much easier working with him, but the amount of patients that they receive is not the same amount of patients that they have in the public hospital. That's why I wanted to work with both. So this is what I think is very important in the surgery first approach. We have to be in the operating room, and we have to check the occlusion right after the surgery. So this is the patient, they did the surgery, they put the rigid fixation, they have in place the sutures, and we have to check the occlusion that is the occlusion that we were planned, either in the digital prediction with the digital surgical splints, or with the model surgical made in the cast models. So I think this is a main situation that we have to check in our patients, in our surgery first patients. This is what is gonna be scary for a lot of orthodontics, the occlusion right after the surgery. So what we do, we start the ortho treatment at the 3rd week after the surgery, and we will see the patients every 2 weeks. We want to take advantage of the wrap. So this was probably my 4th or 5th patient that I had at that time with the surgery first approach. And this is the occlusion that I see when he came to my office. So I was really scared because we are not used to see this type of occlusion right after the orthodontic treatment. So I said, what I'm gonna do with this type of occlusion? The patient, she had a class 2, I show you the case, but taking advantage of the wrap, the light wires that I'm using right after the surgery, and the intermaxillary elastics, then we will be able to correct, as you can see. So now, right after the surgery, who suggests the type and the force of the intermaxillary elastics is the orthodontist, not the surgeon. We will be seeing the patient right after the surgery. We will indicate what type of intermaxillary elastics we will be using, because we have light wires, not heavy wires like in the conventional orthodontic patients. So let's talk of our protocol that we are following. And I'm gonna talk about this protocol with one patient. We do the examination. Like in this case, it was funny because this case, the patient was sent by the prosthetic dentist because she broke the crown of one of her incisors, the upper central right incisor. The crown was broken. So in order that the prosthodontic dentist wanted to do his work, he recommended her to do an ortho treatment. So she came with me, and I saw that she had a mandibular retrusion. She was in a class 2 relationship. She has some amount of crowding. Of course, this case could be treated just with orthodontics, but for me, ideally, it was a surgical case because of her mandibular retrusion. So she accepted to do the orthodontic treatment before the procedure with the prosthodontic dentist. So what we do is a problem list to find out what is to make the diagnostic and the treatment planning at what are our main objectives of this treatment planning. So we have to do two types of predictions. One prediction is going to be what is going to be the occlusion. The occlusion looks going to be looking right after the surgery, and how is the case going to be at the bonding. In this case, we use customized brackets. This is the way, the prediction to fabricate the customized brackets. We use insignia in this case. So we tell the technician that this is going to be a orthodontic case, and the class 2 or class 3 will be solved by surgery. The amount of torque is going to be calculated much easier on class 3 patients when we want to do the positive torque when we are using customized brackets, but it's not a requirement. Then we do the cast or digital planning. We do the surgery in the cast or in the CBCT. At the beginning, we used to do it both. Now, in the private practices, we do it just with the CBCT. We do the digital prediction, and then we will fabricate, print the occlusal, the surgical splints. And at the public hospitals, we do it in the cast, and we will do the surgical splints by the normal methods. As you can see it in this case, that she will have a mandibular advancement and a genioplasty of, say, 7 millimeters of advancement. And then we fabricate the digital surgical splint, and then we print it. So now with the digital simulations, we can do a lot of things and predictions. Like in this case, that she has a tilt of the occlusal plane because she had a big asymmetry. On the right side, she had a short ramus compared to the other one. So she's going to have a double surgery, impaction of the maxilla more in the left side, and then the cuts on the mandible will be different. So now it's going to be much easier to calculate it and evaluate with the surgical prediction. As I said before, probably one of the most experienced orthodontists that is working with surgery first is Dr. Sugawara. But I don't like that much his approach. And Dr. Sugawara is a very close friend of Dr. Ravindrananda. And that's why he convinced Dr. Nanda and Dr. Uribe. Dr. Uribe, Flavio Uribe, is from Colombia, and he is the right hand, or he used to be the right hand of Nanda. Now, Dr. Uribe is the chairman of the ortho department in Farmington, Connecticut. And this is Dr. Villegas, another orthodontist and surgeon that works in Colombia. He's a very good friend of mine. And probably I will say that Dr. Villegas is the one that is introducing the surgery first approach in Latin America. So I have the honor, a pleasure to be lecturing with him. This is in Lebanon, where I met Dr. Nanda in one of the meetings in Lebanon. This is another lecture that we gave in Egypt about surgery first. This is Dr. Carlos Villegas and Dr. Juan Fernando Aristizabal. Both of them are from Colombia. So we are doing a different protocol than the protocol Sugawara is doing. So we will explain that the protocol that we are doing it. So continuing talking about this protocol, we place the brackets 1 or 2 days before the surgery. And we send the patient without wires, no hooks. In this case, we have to place some turbos because the deep bite that the patient had, and we have to remove these turbo bites right before the surgery. Otherwise, the surgical splints wouldn't fit. But this is the way I like to send the patient to the surgery. We place the hooks right before the surgery. We don't have to place the hooks in every bracket because I'm using diamond brackets. We know that we have a vertical slot and it's easier to place the hooks. So it takes me 2-3 minutes to place the hooks. You can place them before the surgery, but I don't want that the patient stays uncomfortable placing the brackets and the hooks. That's why most of the times I will try to do it just before the surgery. As you can see, the patient is already anesthetized under general anesthesia. I place the hooks and then I remove the turbo bites. Then the surgery is made. We check the splints, either if it's a digital surgical splint or is a surgical splint or is a conventional surgical splint. We check. As you can see, the patient doesn't have wires yet. They put the splint, they put the wires to fix the occlusion and to get ready for the rigid fixation. I told at the beginning that for me this is very important to check the occlusion right in this moment when the surgeon already placed the surgical screws and the plates. If we are not agree with the occlusion that we were planned, I would rather ask the surgeon that redo it, take out the screws and the plates and do it everything again. So that's why the communication has to be very straight. Sorry, I went. So right after we are convinced of the occlusion, then right after the surgery, we place the wires. Because of the amount of crowding, in a lot of times we are not able to place heavy wires. Most of the times we place a copper night tie or thermoactivated arch wires right after the surgery. And then I will see the patient after the surgery and we will recommend the type of intermaxillary elastics that we will be using. And at the end of the treatment, we will recommend the type of rotation. So in a class 3, let's talk about our protocol of surgery phase, surgery first in a class 3 patient. So we place the brackets 1 or 2 days before the surgery. We place the hooks. What's happening? I'm sorry, something went wrong. So we place the brackets 1 or 2 days before the surgery. We place the hooks in the operating room, or if you want, you can do it the same day you place the brackets. Then the surgery is done. In a class 3 patient, we want to see a class 2 relationship, but not very bad, just a light class 2 with some overjet. The amount of overjet will depend on the amount of torque we want to give to the lower anteriors. Sometimes I place class 3 elastics right after the surgery to keep that overjet, and then we will be able to do the positive torque in the lower anteriors. We place the wires in the operating room. We will wait for 2-3 weeks so until the patient can open the mouth, and then we will start with the intermaxillary elastics. Depending on the case, we will send the type of elastics. I have to take care about my torque. I want to gain as soon as possible the amount of torque on the lower anteriors. That's in a class 3 relationship. We might be using also some time of box elastics. And we want to gain that torque. The more retrocline teeth we have in a class 3, the more amount of overjet I want to see right after the surgery. So I want to have that space to give the torque to my lower anteriors. And then we will continue leveling and align. And that's it. So let's see some cases. This case, today, I wouldn't treat her with surgery first because it's a short mandible. And this is very hard have the control after the surgery. I might do it early surgery. We will level and align the lower arch and then do the surgery. But this case, we treated with surgery first. As you can see, the class 2, and obviously because the short mandible, we have this type of profile. She had some amount of crowding, upper and lower arch. She has a short mandible. And she has the presence of the third molars. So in the public hospital, they'd rather to extract those third molars and wait 6 months to do the surgical procedures. In the private hospitals, they do the third molars right in the surgical procedures. They just put some plates. So it won't be so, because where the third molars are is where they make the cut. So that's why they have to put some plates. As you can see in the CBCT, the short mandible, we did the cast surgery and the surgical splint. It was planned to advance 6 millimeters, the mandible, and also to do a genioplasty to advance the chin. As you can see it in the cast. At the beginning, we used to do it both, the cast surgical procedure and also the prediction on the CBCT, and do also the digital surgical splint. So this is the way we plan it. On the digital CBCT, we plan to advance 7.5 millimeters, because the deep bite, we were planning to end up with a posterior open bite. And then genioplasty, advance the chin 7 millimeters to improve the profile of the patients. So here are the predictions on the CEF, as you can see, and this is the prediction on the face of the patient. So this is the day we bond the brackets, 1 day before the surgery. And this is the way we send the patient to the hospital. We place the brackets, upper and lower. And because she had a very deep bite, we put some turbo bites. Otherwise, she wouldn't be able to close. These turbo bites, we have to remove them in the operating room. Otherwise, the surgical splints wouldn't fit. We can see here the turbo bites that we place them in the upper arch. And this is the way we send the patients with no wires and no hooks to the surgery. This is during the surgery. When the patient is anesthetized, I start placing the hooks and removing the turbo bites. This is her after the surgery, and this is her occlusion. 8 days after the surgery, we place in the operating room 014 wires, upper and lower, copper nitride wires, and we start. After the 3 weeks of the surgery, we start with the intermaxillary elastics. This is her right after the surgery. 8 days.
Dr. Nassir, excuse me, can you show the elastic again?
This one?
This one?
No, the one before, the elastics, intraoral elastics.
Okay. I think I'm moving backwards. Here, there. Okay.
Yeah.
This is the type, in this case, the elastics we were planning to use because of the shift of the midline.
That is what
That's why we decided to use class 3 on one side with the vertical vector. And in the other side, which had a bigger open bite, we decided to put class 2 with the box elastics. Those elastics are very light. They are 2 ounces, 316, 2 ounces. Because she has very light wires. And also, if we put heavy wires and we are using asymmetrical intermaxillary elastics, and because of the wrap, it will be very easy to have a tilt of the occlusal plane, mainly because the wrap, and obviously of the surgery. That's why these type of cases, I don't treat them anymore with surgery first, because the type of occlusion that we have right after the surgery. So let's continue seeing this case. This is after 8 days. We just saw her to evaluate. She couldn't open wide, so I'm not changing wire. Sometimes I recommend to use some intermaxillary elastics. This is 6 weeks after the surgery. Now we can start seeing the improvement of the occlusion, more in the right side, the improvement of the midline. Remember that we use class 3 on this side. Now the midline is going to that way. Look the way she was at the beginning. Because this was not the really bite. She was very swollen. And when we took the photos and we used the retractors, she was not completely biting because the swallowing, and she couldn't bite the way she was. But still, we have an occlusion that we are not used to seeing right after the surgical procedure. This is her 4 months after the surgery. You can see the occlusion is improving on the right side. On the left side, we still to work more on it. So we took the CBCTs. Usually on those type of patients, when we do the mandibular advancement, the airway improves. Unfortunately, the patient has to move to United States. Their parents used to work in the American Embassy in Mexico. She was from United States, so they have to move back to United States. But this is the way when the doctor in United States received her. This is at 7 months of treatment. You can see the occlusion the way it is. It's much better. We have to work more in arch development to continue using a little bit more of class 2 elastics, but you can see now that she's now without the swallow, and the occlusion is getting better. So that's why I recommend more the surgery first approach for class 3 patients, which is gonna be much easier to manage the surgery first approach. So let's see one case step by step in a class 3 patient. This case, she was recommended by the surgeon. And this girl she had a neighbor that has a class 3, and this patient recommended her to go to the hospital, this public hospital, to do the surgery. And from the hospital, they send it to me. So let's see the case step by step, what we did. It's not a very severe class 3. She has some asymmetry. Her corp of the mandible is a little bit longer on the left than in the right side. The class 3 is more due to the mandible than the maxilla. So these are the complete records because we can see the asymmetry, the chin more to the right side, very slightly. This is the occlusion that she had. She has a full class 3. Can we treat her just with orthodontics? Yes, of course. But in patients, in females that they have a class 3, I would rather treat them with surgery. Plus, these patients came already recommended for the surgery. So we didn't need to convince her to do the orthodontic treatment, the orthodontic treatment. There are some patients that they come with us, we suggest the surgery, but they're either afraid or they cannot afford, and we have to do it and compensate the case just with orthodontics. Anyhow, we treat this case with the surgery first approach. She didn't have that amount of crowding. She already had pulled out the third molars. And as I said, with the diagnosis, we find that the class 3 was due more than the probe was more for the mandible than the maxilla. We took the CBCT, we did the predictions, we did some predictions doing maxillary advancement. This prediction is with a mandibular setback. So let's see the case step by step, what type of arch wires we were using on her. So we place Damon Q brackets from second molar to second molar 1 day before of the surgery. These are the torques that we choose. We choose low torque on the upper 4 anteriors, high torque on the cuspids, and standard torque in the lower anteriors. As you see in the lateral, the retroclination of the lower anteriors wasn't that bad. So we didn't want to have that much of overjet. So we asked the surgeon to leave this patient in a very light class 2, just to give a very little of positive torque on the lower anteriors. Also on her, we place the hooks with the brackets 1 day before the surgery. So this is the way we send the patient for the hospital 1 day before. So they did the surgery on the mandible. They placed the surgical splint to do the the rigid fixation. Then they took out the splint and we check the occlusion. So this is the amount of overjet that we were planning to leave right after the surgery. And now we are checking the occlusion on her and before they put the sutures. And if everything is okay, they put the sutures and then I proceed to place the wires. So now we are placing the wires in this case, you will see the type of wires that we put. We put round wires because of the, even though she didn't have that amount of crowding, I cannot put rectangular wires. So we place round wires, upper and lower, because here it has a lot of more discrepancy on the leveling and align. We have to use an 014 round wire, and I think in the opera it was an 018. So this is the way. So you will see in this diagram, the dark numbers in the upper are the months, and in the light numbers are the days. So we start on the 0 with the surgery. We put the brackets 1 day before of the surgery. In the operating room, we place an 018 copper night tie, upper arch, and 014 copper night tie in the lower arch. This is her 8 days after the surgery. We can even see the sutures with an 018 upper, 014 in the lower. This is the type of occlusion that we are seeing right after the surgery. And this is the amount of overjet that we were planning to have. At the beginning, I'm not going to be using class 2 elastics. The opposite, I might be using very light class 3 elastics to keep the overjet. And as long as I'm increasing the size of the wires, I will be having the positive torque in the lower anteriors. This is the swallowing that she had 8 days after the surgery. This is the way she was before the surgery, and this is the occlusion that we have 8 days after the surgical procedure. This is 15 days. As I told you, our protocol is to see our patients every 15 days to take advantage of the wrap. So we left the upper and lower arch wires 1 month, and then we start using some W elastics, again very light elastics to start settle down the occlusion. This is 15 days after the surgery. We start with that type of elastics, as you can see it here. You can see the force that we were using it, 3.5 ounces. And we continue with the same arch wires. This is her 15 days after the surgery. Then we move on to a 16 by 25 copper night tie in the upper arch and a 14 by 25 copper night tie in the lower arch. This is her occlusion 5 weeks after the surgery. This is her profile. Then, because we start seeing some spaces, we put a CK change in the lower and upper arch. And now we have a 18 by 25 copper night tie, upper and lower arch. We are in the 3rd month after the surgery. This is her 10 weeks after the surgery. As you can see, we made some bends because she had some interference in the upper and lower segments. That's why I made those bends to intrude a little and avoid this type of interferences. We check for the smile arc. Then we move on to a 19 by 25 TMA in the upper arch and a 19 by 25 TMA in the lower arch. And we are in the 4.5 month after the treatment. And she's done, almost done. No crowding. This is 3 months after the surgery, the way she looks. And this is when we debond her. So the treatment time for here was 4.5 months. And this is the occlusion that we gain after we debond with the fixed retainers, upper and lower. This is her panoramic when we debond her, and you can see the inclination of the lower anterior, the incisor. It wasn't that bad, so it was very little the amount of positive torque that we need to place on her. So this is her 4.5 months. One of our main objectives of this type of treatments is reducing treatment times. So, as I said, taking advantage of the wrap that we are not using, that we are avoiding the pre-surgical orthodontic phase. And this is her profile, right and left side when we debond, and the occlusion before and after. In, as an average time, less than 5 months of treatment time. Let me finish the topic with one case that we are doing it surgery first with Invisalign. This is under treatment. She just had the surgical procedure this January. She had 2 orthodontic treatments. She's not happy with her face. In the past, other orthodontists had recommended her to do the surgery. She didn't want to, she was afraid. She had the 2 orthodontic treatments, but she's not happy with her face, and she's not willing to do another ortho treatment with braces. And then she found out about the surgery first approach, and she found out about the Invisalign system. So we are treating her now with this type of appliances. In this case, the planning was to advance the maxilla to improve her profile. She already had extractions of 4 bicuspids. We cannot do a lot of decompensation on her. Her the digital scanning. So we do all the diagnosis with the CBCTs, as you will see. We did the prediction with the Invisalign in order to have the fixation and to use the intermaxillary elastics. We plan to put 4 mini implants in the upper arch and 4 mini implants in the lower arch, as you will see it now. This is the prediction with the mandibular setback and the with maxillary advancement and the genioplasty. So now our diagnosis, it has been modified with my 2 friends and me, Dr. Enrique Gonzalez and Dr. Solorio, we are doing this that we call it best philosophy, that mainly consists, or we design it a method of diagnosis in a defined order, which allow us selecting and individualized mechanics for each case. So what we do is we do a general display of CBCT, watching it coronal, sagittal, and axial. We evaluate the airway of the patient, the TMJ, the teeth and surrounding bone and cortical structures, and we do an interactive analysis. I'm gonna just give a very little review what we do before we are planning the torque. We superimpose the CBCT on this type of program. We evaluate the TMJ, and also we can, this program can help us to choose the right torques and evaluate the cortical bone. So that is gonna help us, or it's helping us a lot, mainly in evaluating the amount of torque that we are planning to have in each of our patients. It's funny because today we are lecturing, we are doing a webinar in different times. Dr. Solorio just finished giving a lecture in Argentina. Dr. Enrique, which is here now hearing us, will give a lecture, a webinar in Honduras. And now I'm speaking to you in Palestine, which is a big honor to me. So let's continue with the same case. We evaluate the airways with this type of diagnosis that we are doing and using this type of program. Evaluate the TMJ before we start placing the brackets. Sometimes we have to find the discrepancies between CO and CR and do a better diagnosis in our treatments. So this is the case of her. The way we diagnose the orthodontic procedure with the surgery first approach. Her condyles were okay, even though the shape is not the one that we were expecting. So this is the evaluation. Unfortunately, we don't have that amount of time. Those are the predictions that we did on her and the surgery on the cast, and also the digital planning for the surgery. So this is her. We place the mini implants 2 days before the surgery. We have already ready the aligners, and this is the way we send her for the surgery. This is during the surgery where the maxilla is completely loose, and that's why they are gonna be using the mini implants to do to place the surgical splint, as you are seeing in the video. And then after they do the fixation, as you can see it here, oops, the video is not running. Okay, anyway. So those are the changes right away. And also we can be using our intermaxillary elastics, light ones, that they can be using from the mini implants or even from the aligners. So she's on treatment now. So I'm finishing. If you have any questions, I will be more than happy to answer.
Thank you very much, Dr. Nasib, for a very nice lecture, a very nice way of treatment. We have some questions from the attendees. I will read them for you. The first one, is there any reason why you don't place the hooks while bonding, but just before the operation?